Hello everyone. Today we'll be talking about exodontia. My name is Dr. Stanley John and from the Department of Oral and Maxillofacial Surgery. We'll briefly discuss about indications for extraction, contraindications, pre-surgical assessment, how do you assess a patient as well as the tooth and its surrounding structures before extraction, extraction techniques, how do you position yourself, your finger grabs, all of that, and your principles of elevators and forceps. Complications of tooth extraction. So, tooth extraction is the painless removal of the whole tooth root, with minimal trauma to the investing tissues. So the wound heals unevenly and post-operative prosthetic problems are minimal. This definition was given by Jeffrey Elko. Indications for extraction include carious tooth that are non-restaurable, that is grossly decayed, or root stumps that cannot be RCT treated. Predominantly involved tooth, overweight and deciduous teeth. To facilitate ortho treatment, you need more space in the arch to extract premolars. Teeth involved in significant infection, malpositioned or malposed teeth. Teeth involved in tumors, fracture, if the root is fractured, impacted teeth, supernumerary teeth, teeth associated with pathological lesions. Now, contraindications, there can be absolute contraindications and relative contraindications. So relative contraindication, you just need to be careful before extracting, while extracting the tooth from tooth in the patient. Absolute contraindications include central hemangioma and navy malformation. This can cause severe bleeding. These cases should be identified and avoided. In relative, the local and systemic contraindications. Local include acute cellulitis or acute necrotizing ulcerative gingivitis. Systemic include uncontrolled diabetes mellitus, hypertension, bleeding disorders. If he has any cardiovascular diseases, he's taking any antiplatelets, these need to be stopped. If he has any liver disorders, his drugs need to be modified accordingly. And patients on long-term steroid therapy, he need to take these steroids. His dose should be increased. On the morning of extraction, he should be given morning appointments. It should be minimally traumatic. Um, you shouldn't cause him too much stress. Teeth that have undergone radiation, these can lead to osteoradionecrosis. So at least your extraction should be done after at least 6 months to 1 year after radiation therapy. Pre-surgical assessment, you should take a proper medical history, all of his dental history. If he has undergone any previous extraction, you get to know if he has done any dental treatment. He'll have taken local anesthetics. We usually use lignocaine, so you get to know how difficult the extraction was, or if he was allergic to lignocaine or any of the drugs that was prescribed. Then patient's emotional maturity, if he is an apprehensive patient, if he needs any uh, alprazolam, any of it, uh, or any other stress reduction protocol should be carried out. Should examine the patient fully, not just the tooth. Radiographic examination can be done. Clinical examination, the you should see if there is presence of infection, restriction of mouth opening. If the mouth opening is not adequate, it will be very difficult to extract posterior tooth. You won't be able to reach forceps till the posterior end. Condition of the crown of the tooth, if it is grossly decayed, it will be difficult to apply forceps. And mobility should be seen. You should also examine the adjacent tooth, see if the other tooth are mobile. And, there have been cases where the patient has complained that my other tooth was fine after the doctor did it. It's mobile now. Note down all of these in the chart. Should see which all tooth are mobile, which tooth are firm. The alignment of tooth in the arch. If the tooth is malpositioned, it will be difficult to apply forceps to these tooth. Then you should see if the tooth is close to the maxillary sinus. If only a thin layer of bone is present, the patient should be told that there is chance for communication. So once he is notified, it is fine. Even if you get a communication, you just have to close it. So if you don't inform the patient, it will be a shock for him, and doctor did this and this happened. And so patient should be informed prior to see the size and shape of tooth. If it is a bulky root, it will be difficult to extract the number of roots. All of this, curvature, shape, length, and size of the root should be seen. If the root is previously endo-treated, the tooth can be brittle. So, yeah, there's chance for transcellular extraction. The patient should be notified about that also. Then you should look for the condition of the surrounding bone. If it is sclerosed, or then it will be difficult to extract. The bone won't give away when you extract. So that also should be informed to the patient. The patient should be told that stands for transvaluable extraction if it doesn't come out. Then principles of extraction include liver principle, wedge, wheel, and axle principle. The liver principle has three components: fulcrum, load, and effort. When applied in elevators, the handle that is the effort. So the first order principle is applied. Is handle that is the effort, the tooth that is the load, and intertidal bone is the fulcrum. Wedge principle. You insert an instrument between you wedge an instrument between the tooth and the bone. So in elevators, a straight elevator is applied between the tooth and the bone and to separate the attachment of the periodontal ligament. In forceps, you hold the forceps as apical as possible, and the mucoperiosteum gets displaced and the bony sockets are expanded, which results in slow separation of the periodontal ligaments. Wheel and axle principle, you can use it, instruments that work by this as cryos or crossbar elevators, forceps. So when you're using a forceps, when you apply a forceps, it comes in a you extract the tooth in an occlusal and buccal direction, so that it comes in, it gives in a wheel kind of a direction. So the effort is applied to the circumference of a wheel, which turns the axle so as to raise the weight. So that is the principle that is applied even in an elevator. When the same is applied even when you're using a crossbar or a crier. So, principles of forceps technique, the beak should be seated as apical as possible. The beak should be placed parallel to the long axis of tooth, and excessive force should be avoided. It should always be controlled force. Should use excessive force. It's never about muscular strength, but about technique. So that should be kept in mind. Basic steps in extraction include grasping the tooth, expansion of the bony socket, mobilization of the tooth, and then delivery of the tooth. So the basic forces that we apply are apical force, the initial apical force that you apply on a tooth. You engage the forceps as apical as possible, then the buccal force, lingual force, rotational force, and frictional force. For a mandibular anteriors, you can extract using rotational movement, buccal and palatal movement. Uh, sorry, maxillary anterior, buccal and palatal movement. And canines will be a bit more difficult because of its long root, but the anteriors, the centrals and laterals are very much easy with the rotational movement. Yeah, maxillary first premolar, there'll be bifurcation for your first premolar from the um, middle one third or apical one third. So it varies from tooth to tooth. There'll be tooth without bifurcation also. So it is very slender and it's easy to break off. So give a buckle and more of a buckle and little of palatal movement. A little bit of rotational force can be used, but they should be very much controlled and not to. You should not give excessive force. Maxillary first and second molars, you should always remember the anatomy in your head. The first, the mesial, the buccal roots will be, the mesial and distal buccal roots will be close to each other, and the palatal root will often be a little posteriorly placed, a little away from each other, away from these buccal roots. So a more of buccal force should be given, and with minimal palatal force. Mandibular anteriors, you can use a Stopius technique by using just an elevator. You can fixate it and then extract the tooth using forceps. It's quite easy. Mandibular premolars, they may have their roots tapered towards the distal side, so rotational forces should be avoided. You can use slight rotational forces if you can use control forces. Only the second premolar can initially, you can deliver it through rotational forces, or else you can use a buccal and lingual force. Mandibular molars, they have two roots you extracted by giving buccal and lingual forces, as well as a figure of 8 motion is used. I'll show you a video in a few slides down, explaining all of this, the chair side position, all of this. So for the first, second, and third quadrant, you should stand in front of the patient at 8 o'clock or 7 o'clock position. And for the fourth quadrant, you should stand behind the patient, and the chair should be as below, as low, so as to see the arch from behind the patient. So for an upper tooth extraction, your the arch should be 8 millimeter above your elbow, and for your lower arch extraction, it should be at least 16 millimeter below your elbow. So your dental chair should go all the way down. And you should always use your supporting hand to support your alveolus while extracting. I've seen people extracting just by all you concentrated on all you concentrate is on just the tooth coming out, nothing else. You don't see that there's a patient attached to the tooth. So you should support the alveolus. You can even feel the tactile sensation of the tooth giving in within the bone, and also it helps in retraction. So you can for the first and second quadrant, you use your thumb and your index finger. You support your alveolus with the thumb and index finger. For the lower teeth, while you're supporting it, you also need to support your mandible to avoid dislocation of the mandible, so that your force that you're applying, downward force that you're applying on the elevator should be that is the force that equal force should be delivered upward also with your supporting finger.
Welcome to this short video explaining the basic use of forceps for exodontia. It's important that you appreciate the use of elevators and also fixators. This will explain the basic principles of forceps use. It's important that you do not just learn the numbers of the forceps, but learn the anatomy of the forceps and how they are applied in the mouth. Not all forceps will carry numbers, and it's essential that you can recognize the anatomical features of forceps and how you use them. Please use this video in conjunction with the teaching material for the exodontia tutorial. Here we can see a selection of forceps for both right-handed and left-handed operators. Initially, separate your forceps out, and you will be able to identify that these forceps on the left-hand side are for a right-handed operator due to the curvature being where your fingers would be. For example, a right-handed operator would hold the forceps like so, as opposed to these three, where a left-handed operator would hold them like this, with the curve of the fingers. These forceps are universal and can be used by either a right-handed operator or a left-handed operator. And these forceps also, for lower extractions, can be used for a right-handed or a left-handed operator. Focusing on the forceps on the top row, these forceps can be used for molar extractions, and it's important to distinguish between the beaks of the forceps. The beak should be towards the cheek of the patient. So, for example, these forceps, for a left-handed operator, the beak would go to the cheek, therefore they would extract upper left molars. Conversely, these right-handed forceps would extract the upper left molars because the beak is also to the cheek. It's important to distinguish between your molar forceps with the beak being to the cheek. So these are for the upper left and these are for the upper right. The other forceps you see here are for premolar extractions, so upper fours and upper fives. You'll note that they do not have a beak. And the universal straight forceps are used for anterior teeth, so upper incisors and canines. The two forceps here are for lower extractions. These are used for anterior teeth, including the premolars. And these, you will notice, have beaks similar to the upper forceps, and these are for lower molars. The beaks on all of the molar forceps are intended to aim towards the furcation of the tooth. This video demonstrates extraction techniques for a right-handed operator. Where appropriate, I've discussed the different forceps for a left-handed operator. The principles are the same for a left-handed operator, but reverse the positioning. This is further detailed in your extraction tutorial. So to extract the upper right molars, I'm going to demonstrate here as a right-handed operator. The beak goes towards the cheek, so it's buccal, and the curvature of the forceps are towards the fingers. The patient should be at about elbow height in the chair and 45 degrees. With a non-dominant hand, ensure that you support the alveolus, and then ensure you have the correct tooth before placing the forceps in apical direction, pushing apically, ensuring that you then support the alveolus and gently push buccal. Slowly bring the forceps back to the midline and ensure you continue the buccal motion back to the midline until the tooth starts to reverse. Once the tooth has been extracted, you then ensure that you have the apices on the tooth you've extracted and squeeze the socket. This video will demonstrate the extraction of the left molars, and again, as a right-handed operator, the curvature of the forceps is my fingers and the beak goes to the cheek, so it's buccal. With your non-dominant hands, support the alveolus and ensure the soft tissues are out of the way. Drive the forceps apically up the molar tooth, ensuring that you have a good grip. Gentle buccal movements, gentle buccal movement back to the midline, extract the tooth as within 3 minutes. Again, check the apices once the tooth has been extracted and squeeze the sockets to ensure hemostasis. To extract upper left premolars, again as a right-handed operator, your forceps will have a curve towards your fingertips and there's a single beak on these forceps. With the non-dominant hand, support the alveolus. Ensure the forceps are on the correct tooth, slide them up apically onto the root surface, and with premolars in the maxilla, ensure rotational movements with some buccal delivery. Again, ensure that you check the apices once it's been extracted and squeeze the socket. As a right-handed operator, I'm going to extract an upper central incisor. These forceps are universal, whether you're right-handed or left-handed. They have a single beak. With your left hand, support the alveolus. Drive the forceps up onto the root surface, and for anterior teeth, from 3 to 3, rotate, and then eventually the tooth will be delivered through the socket. Ensure the apices are tight. To remove molar teeth, the forceps are universal whether you're right-handed or left-handed. As a right-handed operator, you want to be stood for lower right extractions behind the patient, with your non-dominant hand supporting the mandible. Ensure that your thumb is lingual, your fingers are buccal and underneath. The forceps need to be open, placed on the correct molar tooth, driven down apically, and then a figure of 8 motion, to expand the socket and then deliver the tooth quickly. Again, ensure that you check the apices once it's been extracted and squeeze the socket. To extract the lower left molars, as a right-handed operator, you would stand in front of the patient with the same principle. Non-dominant hand supporting the mandible, and the forceps ensure you're on the correct tooth, drive them down. The figure of 8 motion to deliver the tooth quickly. Again, check the apices and squeeze the socket to ensure homeostasis. To lower anterior teeth to the midline, you want to stand behind the patient, and again, for premolars and incisors, rotational movements, supporting with your non-dominant mandible to rotate the conical roots and then deliver properly. When you pass the midline, I would suggest you stand in front of the patient to extract the lower left teeth. Ensuring that your non-dominant hand supports the mandible and you rotate the anterior teeth to deliver. Ensuring that apices.
So extraction, the order of extraction is first you extract maxillary teeth if it is a total extraction, because debris from your, if you extract the lower tooth first, your debris from your maxillary teeth can fall into your sockets. So it is always good to extract your maxillary teeth. So maxillary posterior teeth except the first molar should be extracted, then the anterior tooth except the canine, then your first molar, and then your canine should be extracted. Same way in the mandibular tooth, mandibular posterior should be extracted first, then except the first molar, and then the mandibular anteriors except the canines, and then molars and canines can be extracted. Coming to the complications, there can be pre-extraction complications, complications that happen during the extraction, and post-extraction complications. Pre-extraction, you can have difficulty in achieving anesthesia. Maybe you're blocked in work well, or so there is infection. LA won't be acting on your acidic medium, so there's difficulty in achieving anesthesia. There's difficulty in the patient can be uncooperative. There's difficulty of access. If the mouth opening is little, there's no 3/5 mouth opening. It can get very difficult if the patient has bulky cheek, posterior tooth. It will be very difficult to extract. If it is crowded or misplaced, it can be difficult to extract. So intraoperatively, you can extract wrong tooth. So you should always double check which tooth to be extracted before applying the forceps. You should meticulously double check, because extracting the wrong tooth is a very serious issue. So you can fracture the tooth, you can fracture the adjacent alveolar bone. So you should always give a good finger support and should not use the force. You shouldn't injure adjacent teeth. You can fracture the tuberosity. Internet is okay, but you should try not to do it. You can, the only problem that you get is there can be excessive bleeding, and if the patient goes for a complete denture, he won't have proper retention. So try not to do it. So some cases the tooth might be ankylosed, and you can fracture the tuberosity along with it. So try to avoid it. The root can be displaced into the maxillary sinus. If it is displaced, you need to take it out. If it is an infected root, you can use a Gladwell loop procedure and get into the antrum and try to remove it. Because lacerations can occur, you should always care for your soft tissues. Hemorrhages can be usually controlled with pressure packs or gel foam. Proper suturing. TMJ dislocation can occur, so you should always give hand support to your mandible. Equal opposite force should be provided for the mandible while you're extracting lower tooth. So if at all it gets dislocated, so acute dislocation will be easier to treat. You just You need to know the technique. You need to bring the mandible down in a downward, backward, and upward direction. The mandible shoots back into place. So chronic cases are more difficult to manage. So acute dislocation, if you know the technique, will be pretty easy to manage. Postoperative complications again include hemorrhage, hematoma, swelling, pain, dry socket, infection. In case of hematoma, ice packs can be applied for the first 24 hours and followed by heat application. You should reassure the patient. You can give a course of antibiotics so that it doesn't go into infection. Hemorrhages might be due to the patient might have uh, you know applied excessive force on the mom by using a straw or taking warm hot fluids, or he must have coughed excessively, or the suture must have come out. You can resuture and give a pressure pack, and that must be good enough. And you should check also for as BP if his blood pressure is elevated. That can also have he's hypertensive, so that can also lead to hemorrhage post extraction. Then swelling can be managed with ice packs. Pain can be managed with with analgesics. Gentle extraction pain is not much. You can control it with NSAIDs. Dry socket, you should ask for proper history. The pain usually starts from the second day. You need to give a suboxide eugenol pack and recall the patient every 2 days and change the pack. So zinc oxide eugenol pack acts as an oxidant, and so it gives pain relief to the patient. You can give analgesics SOS and gently irrigate the socket also. So the pain occurs because the clot has gone off and the nerve endings are exposed from the socket wall. So in case of infection, you can, if there is pus, you can drain it and then give a course of antibiotics. So extraction is usually doesn't cause much of complication. You just need to know your techniques properly. It's not about muscular strength; it is about technique. So you learn the proper technique. It is fairly safe procedure. Thank you. Thank you for your patience.